Changing the Narrative, a podcast on a mission to dispel viral misinformation concerning public health and public safety. Hi, welcome to Changing the Narrative podcast, or CTN pod. Today, for episode 1, we'll be talking about the myth that the quote-unquote opioid epidemic is a white problem. And I'm turning over to our host, Tracy Gardner. Take it away.
So my name is Tracy Gardner. I'm the Senior Vice President for Policy Advocacy at the Legal Action Center. We have been around for 50 years fighting discrimination against people with HIV, with substance use disorder or substance use histories, and people who've been involved in the criminal legal system. In May of 2024, I will be co-executive director of the newly formed Black Harm Reduction Network, along with my co-executive director, Joy Rucker. And so looking forward to people seeing what we're gonna do, because it's gonna be a lot. And happy Black History Month, the shortest month in the year. Wonder how that happened. Like folks I know say, every month is Black History Month, because our history is infused with everything that has to do with this country. And as Black folks in the diaspora, the world. So today we're going to talk about dispelling some myths. And when information gets into, I mean, this is not unique to Black communities, but certainly whether we were talking about Magic Johnson or the way that information is exchanged in Black communities has evolved over many decades, many centuries in this country. And so where we are more recently is the information we can get from the internet, the information that goes viral, the information that is the fodder for the talk shows and the podcasts. And as this is happening, and certainly a lot of this was influenced by the impact of COVID and how we communicated and the scope in which we could communicate. We also saw a number of public health emergencies happening in addition to COVID. And one of them is the dramatic uptick of overdoses in Black communities around this country, which has persisted. I'm saying everywhere there's an MLK Jr. Boulevard, there is significant destruction and damage from whether you call it the overdose epidemic, fentanyl poisoning, but we don't talk about opioids, right? Because that is dog whistle for the prescription pain epidemic, which was widely seen to affect primarily white people. And so there's a whole lot of needing to correct and amplify what the true evolution and history has been of this latest health emergency related to drugs that is having a major impact on Black communities. And it should be mentioned also on Native American Indigenous communities. And one could say the two populations have been the most targeted by government terrorism since we arrived, and since Black people were brought here, and since Native Americans were introduced to the white conquest of this country. So I like to start with historians because, you know, we're doomed to repeat and in danger of repeating what we don't acknowledge we've already done. So I'd like to turn this over to Dr. Helena Hansen, who will introduce herself, because I'll just fangirl if I try to introduce her.
Thank you so much. The fangirl goes the other way, Tracy. Thanks so much for having me. I'm Helena Hansen. I am at UCLA in the Department of Psychiatry, and I am an anthropologist, I try to pass as an historian. I'm an anthropologist and addiction psychiatrist. And, one of the things I want to start with is that I trained in addiction psychiatry in the moment of a big sea change in the way that addiction was seen in the field of medicine and the way it was responded to. I'm talking about the late 90s to early 2000s, when I observed a new medication, buprenorphine, being rolled out to treat this new cohort of quote unquote suburban youth, code term for white Americans, who were being affected by opioid overdose and harms because of supposedly the aggressive marketing of the pharmaceutical manufacturers, this new class of newly patented expensive opioids. And so I saw this curious thing happen in front of my eyes, that I was working in a large public hospital, in New York City, with very few white educated patients baseline. And most of the patients who I was treating in the methadone clinic were Black and brown, as we'd predict, and were, using heroin as a reason that they were referred to methadone. But there was this little clinic in the primary care area, not psychiatry, not anything, the primary care clinic. Met once a week, and a bunch of educated white patients were going there. It was very odd. And I discovered that they were going there because that was one of the few places they could get buprenorphine with their public insurance. These were people who had lost their employment recently due to either prescription opioids or heroin use and everything that had gone along with it, and had public insurance. And they learned that the hospital I was in offered it as a new medication. And it was the same drug class, an opioid, used in the same way to keep people maintained and keep people out of withdrawal, but it had a completely different legal structure, policy structure, social identity, clientele, night and day. And so I began to track this story, and I began to get curious about why it is that in the beginning, in the late 90s, we were thinking of the quote unquote opioid crisis as a white crisis. Why would we think about it as a white crisis? Why were there, middle class and affluent and also working class white people, taking these prescription opioids and overdosing at high rates? So I began to dig into it. And in brief, I don't want to go wax on too long, but in brief, this was an example of race being baked into a marketing campaign from the very beginning, with the manufacturers realizing that if they could develop and sell themselves as having a less addictive opioid, that the clientele would be people who are white and insured, and that they had to get around regulators and craft a very different social identity for this kind of opioid than the many decades of prohibitionist anti-drug use of, demonizing images of Black and brown drug users had crafted. So our prohibitionist policies are very rooted in an image of the addict, quote unquote, as a Black or brown person. And these pharma manufacturers and all of their collaborators at FDA, DEA crafted a whole other track for white people who were seen as deserving and less vulnerable to addiction, or, whatever, less risky. And then following all of the fallout from that, the harms from that, they crafted another track, another less criminalizing, less jail and prison based response, a medical response that nonetheless was not a public health response. And I know we're going to talk about this later. It was a for-profit pharmaceutical based response. And so buprenorphine, otherwise known as Suboxone, was legalized for use in private offices, prescription based, treating people with opioid use disorder, just like any other person with chronic disease, just like someone with asthma, diabetes, or hypertension, treating them in private doctor's offices, primary care offices with long-term medication. This was a whole reframing that was based on the white image of the clientele. So I'll leave it at that.
Thank you, because that sets us up very nicely for the origins and also the the underpinning, what was unsaid and didn't need to be said by the pharmaceutical companies marketing prescription pain medication is playing on this image of you won't get addicted. This is less addictive, i.e. you won't be like those people. And we see a lot of racial discrimination in the healthcare setting overall, but there are very few people who are more contemptible to the healthcare system than people who have substance use disorders, who are in the grips of their health issue. And we know that extends even to people who are suspected of being drug users. And so again, my experience has been with friends who have sickle cell, and when they've had crises, and opioids are definitely indicated for that level of acute pain, they have been turned away, they've been shamed, they've been unable to get the medication that they need in the emergency room because of ignorance around sickle cell, and of course, this overall clampdown now on opioids, but also because they think they're dealing with someone who is quote unquote drug seeking. So the first time I heard the term OBOT, I'm like, damn, another freaking acronym, office-based opioid treatment. And it was clear that that was a direct response to the image that's been perpetuated of Black and brown people standing in line, waiting for their daily methadone, looking like the dregs of the earth, blight on the community. And of course, that was not we needed an alternative to that. And then finally, it should not be a surprise that there's a significant gap or disparity in Black people access to Suboxone, not surprisingly, because it wasn't built to address us, versus people who have primary care, who can access primary care, people who have health insurance that covers it, but also people who know that that option is available. So Mark Jenkins, I want you to introduce yourself. And I almost want to talk about how we first met. You know that I have such love and respect for you as one of the OGs of harm reduction in this country. And you are part of the history of Narcan and of syringe exchange in ways that I don't feel like you get your full attention and full flowers for. So please introduce yourself and give us that overview of the work that you have been doing.
Thank you, Tracy and Dr. Hanson, Leo. My name is Mark Jenkins. I'm the founder and CEO of the Connecticut Harm Reduction Alliance, formerly the Greater Hartford Harm Reduction Coalition, and also ED of Reduce Harm Incorporated, RHI, which is now our national TA and expansion effort, primarily around syringe exchange, because these are, and I'm glad you mentioned that, Tracy. And we first met, I'll go back to that, in, I want to say it was that first meeting of the Black Harm Reduction, the inaugural Harm Reduction Network is my first memory. And us having these meetings talking about this movement that I was really glad to hear about, but at the same time worried because, harm reduction, while it was born out of the HIV movement, really a lot of the players, if you will, the folk who helped to really stand it up and keep it going, even though we had those like Imani Woods, people that were there in the beginning, like Joyce Rivera. There are so many others, but in order for in addition to being really grateful that this was happening, I was also worried, because what happens so often is we get things started and it doesn't follow through. And then really in the past few years, and seeing how everything has unfolded nationally, and as I saw things happening as well, time became of the essence, and is of the essence right now. And I'm so grateful for BHRN being in the place that it is. But at the same
We're going to talk
time,
about Black Harm Reduction Network, trust and belief.
Black Harm Reduction Network, but also at the same time where here comes the Fed again, and both from SAMHSA, CDC, you know, how things they have found a way to make this palatable to themselves, and at the same time co-opting the very basics of the harm reduction movement and reducing it to Narcan and fentanyl test strips, taking it away from the people, and again, like communities that are best situated to serve these populations that are at risk, and now moving it and putting it into the hands of recovery community organizations, or once again, abstinence-based models, where harm reduction, as I know it and as I was raised in it, was really a model, again, born out of that HIV movement, but primarily formed around, I tell people the difference between us and everybody else is that we love everybody. You know, some we love to see come, others we love to see go. But it's a true love for everybody. It's a radical love because it's a non-judgmental way in meeting the needs of individuals and really trying to have conversations with them and understanding that they're not the sum of their present circumstances.
That's right. And Mark, we've also had discussions about, and again, this goes to the narrative that is not getting to Black communities in a way that has been fully covered, very amply covered in more, mainstream white media, which is this idea of abstinence and harm reduction as polar opposites rather than part of the array of choices and options for people to be able to make. Both of us have had experience with 12-step, and we understand that it has its benefits. It's not the only way. It was seen as the only thing for a while, and a lot of Black folks came up in 12-step with its messages. But where we are now is that Black folks are dying, and if Black folks in recovery, however they achieved it, aren't speaking and weighing in on these deaths that are happening in our community, and that we're losing, whole strips of generations of people, then that's going to be a problem. But I was hoping in particular we could talk about that tension.
Well, and this is all based really in fear. Folk who have long-term recovery, if you will, and abstinence-based models have been always given that dialogue, have been given that narrative that if you want what I have, you have to do what I did. So anything that doesn't look like that is not only foreign, but it's threatening to the belief systems. So which, just amplifies the stigma associated with there being other means than abstinence in which people can lead productive lives, whether it be, through medication-assisted treatments, or even controlled use. Like, what a concept, and even more, like other countries have even gone into, in addition to medication-assisted treatments, but actual using drug therapies where it gets a lot more complicated. But we've not had those conversations. And again, because I don't think there have been enough of us also in positions to drive the narrative. Again, the importance of a group like the Black Harm Reduction Network, which has, leaders, Black leaders, brown leaders, that are coming up and have this information, because it's not just about the information, it's how we're able to translate it so that, again, that it's palatable. Because we find this in everything in society right now around harm reduction. It's not, we know that there are, safe injection facilities all around the world, but it will not happen in the United States under that language. So we've had to have language that is palatable, that people can accept and digest, even though it's the appropriate public health response, because the most effective public health responses aren't favorable to the average, folk. And what we find, just, I use this quite a bit, Tracy, is that insanity in the treatment world has been defined as doing the same thing and expecting different results. But yet, if you look at where we are right now with the federal government, with all of the information that they have to novel methods of addressing this population, they continue to go around the block and figure out ways that just are doing the same thing, that are punitive, that are based and steeped in racism, stigma. They don't work. And we still try and find, they're trying to craft it in different ways, and we find ourselves back at the same point. And instead of taking that straight line, that shortest distance between 2 points.
That's exactly right.
I wonder
it-
if I could
Please,
hop in on that,
please,
because
Dr. Anthony.
I think Mark is just so on point with that. So we're in a society where there is, the whole society is built on a refusal or an denial of all of these.
Refusal, not denial, refusal.
Willful.
The whole society is
Willful.
built on that. So a denial and a refusal of the structures of racial oppression, of class oppression that are producing the deaths that we're seeing now. So the national response really has been a very technocratic one. They were forced because of the racial identity and class identity of the people that in the late 90s were seen as the most effective to come up with this alternative non-criminalizing track. So it was a medicalized one, but it was all still based in for-profit industrial solutions. So a lot of the federal funding that was supposedly going to address the overdose crisis was directed to subsidize pharma and biotech companies to come up with yet more technological solutions that would, of course, be affordable to and targeted to more affluent white clientele. And so there's absolute refusal to look at the racial capitalism and the racial and class underpinnings of the root causes. And so what we're seeing now in this moment where African Americans and Native Americans are dying off at higher rates than white Americans is this incredible mismatch between where our investments and our energies are going. Our energies are going into these, consumable devices and products that are accessible to a more affluent and white clientele, and there's a complete ignoring of the social underpinnings, the structural underpinnings. And what Mark brought up was that harm reduction movement is a movement. It is not a technocratic solution. And what's happened at the federal level, I think, is a hijacking of the harm reduction logic by much more individualized, technologically focused entities, and a complete undermining in the process of the social movement and justice, health and race justice elements of established and successful harm reduction organizations and groups. If you go to the really foundational harm reduction organizations, they are far more than a place where syringes are handed out or Narcan kits are handed out. They are
That's right.
places where people are received, given their full dignity, you know, offered the food they need, offered the rest they need, offered the washing machines they need. You know, it's like it's a much more socially rooted and justice oriented phenomenon. And so how can we call attention to the underpinnings, to the way that race and class inequalities and oppressions are driving this whole set of quote unquote crises that we're seeing now, and the fact that harm reduction has to be supported as a social movement, not as a technocratic solution. There are reasons why, and I won't go into it just now, but maybe, you know, one of us can talk about the reasons that a crisis that was initially defined as a white crisis has really morphed right now and is actually a very, very urgent Black and brown crisis, as well as, you know, a population-wide crisis. There's a really interesting history of that, the different waves of overdose and waves of toxicity of substances out there. But we're talking about a Black and brown crisis that is being met with these, you know, technocratic solutions geared towards a white affluent clientele. And that's why we're seeing among the highest, probably the highest death rates in any recorded human history from drug overdose.
And yet, as the effort to let folks know that this is happening, because it's not as though these deaths are, that people are unaware of the impact in Black communities. It's the, what is it, kind of the denial, but it's denial that's been informed by trauma. It's denial that's been informed by very justified suspicion. It's a denial that we saw in the days of HIV, when the deaths related to HIV and the person was gay, and we were trying to have funerals at Black churches, and no one wanted to talk about the why, right? Data collection has not been our friend, as an example. And though we need the data, ostensibly to inform a better governmental response, it comes with serious downfalls. This phrase, technocratic solutions, is going to be burning in my brain. And this idea that when a public health emergency happens to a non-marginalized population, the changes are dramatic. And again, I go back to HIV. I worked at Gay Men's Health Crisis. I saw the mobilization that happened when white gay men were experiencing the stigma and the disdain in the hospital, the health and hospital system, as they came in with the effects of HIV and full-blown AIDS. And they said, fuck no, we are going to build a more humane, a more clinical, a more comprehensive system to respond to HIV and AIDS, denying the fact that HIV emerged first among Black and brown injection drug users. They got the benefit of that political and economic response to HIV and AIDS, but let's not be fooled. If that had been discovered as the primary population, we would not be seeing what we're seeing in HIV as a chronic and manageable disease now. I didn't think I'd live long enough. I started doing this work in 1989 as, you know, advocacy, and I saw so many Black gay men, Black women, Black drug users dying, and no one felt that these populations were sufficient enough or mattered enough to change public policy. But when white gay men got involved in the public policy, we got Ryan White, we got HIV prevention planning through CDC, through SAMHSA, and I'm using the acronyms for the federal agencies. We have a whole state agency involved in administering these giant funding omnibus programs to address root cause from pediatric AIDS all the way to the need to support community and regional networks. And so that's why we are where we are. But let's not be fooled about why the changes are happening in the quote unquote substance use disorder field like lightning speed. 10 years ago, the addiction agencies around this country were going hand to mouth with funding they were trying to get from the federal government, from the state government, from localities. And then once we recognized, or once there was a recognition of who was being affected, the innocent, the accidentally addicted, funding rained, poured down through federal programs, through philanthropy, and everybody wanted to talk about what they wanted to do about opioids, right? So, you know, taking it back to the occasion in which Mark and I met, 100 Black people gathered during a pre-conference of Drug Policy Alliance because we were frustrated with the narrative that was being advanced about a kinder, gentler approach. It seemed to willfully ignore the history and the divestment of how we have responded to the crack and how we responded even to our previous opioid epidemic when it was just heroin, right? It was a heroin epidemic. That's an opioid, but we have war on drugs and harsh sentencing and mass incarceration from that. And again, I contend when white families discovered the addiction treatment system that was set up for us, they said, fuck no.
Well, you know, we see some of the same laws that happen as a result of powder cocaine versus crack cocaine and how those laws were set up. The same thing has happened now with heroin versus fentanyl. You know, again, it is not those Black and brown individuals bringing the stuff into the country, yet and still the laws are set up to punish.
Say that again. Are we manufacturing fentanyl?
We're not. We're not. You know, it's coming in from China and Mexico. We don't have any planes bringing it in, you know, and we're definitely not bringing it over the border. And we have to understand that the market, there's so much more that's behind this that we don't talk about. And the
volatility. Real quick, I think.
Leo.
Yes. So this is Leo Beletsky. I'm a professor of law and health sciences at Northeastern, and where I run the Action Lab, which is producing the Changing the Narrative podcast. And so grateful to have all of you as our inaugural episode. I think Mark's point is really important, which is that, and we all have been talking about this already, but basically, you know, the responses historically, the misguided responses to drug crises have laid the foundation to the misguided response of the crisis of today. And the reason why we're in the third decade of this crisis and we have failed to make any headway because overdoses have continued to spiral is because of this incredible commitment to punishment and racial oppression, you know, using drug policy as an instrument of racial oppression. And that's what's killing people. It's killing Black and brown folks, it's killing Native folks, and it's killing white folks. And we, you know, despite the rhetoric of a public health approach, really have failed to live up to that rhetoric. Dr. Hansen has talked about, you know, the sort of using profit-driven, you know, medical pharmaceutical industry responses under the banner of public health, which it is not. But I think it's worth also noting that, you know, the kinder, gentler response never was. There wasn't really a kinder, gentler response, because if you look at the rates of drug arrests, if you look at the emergence of laws criminalizing fentanyl distribution that Mark has already talked about, if you look at the rhetoric around, immigrants coming across the border trying to poison our communities, quote unquote, and blaming, Mexico and China to what is really a domestic problem. These are all ways of harkening back to how our drug policy has really evolved from the very beginning, which is through a lens of racial and xenophobic prejudice. And that's, one of the top reasons why we really haven't embraced a truly public health approach that addresses the structural determinants of health, that addresses the demand for opioids and other drugs on the illicit market. We're really, we will continue to see those overdose rates skyrocket until we, are able to look inward and figure out how we, craft a truly public health response. And I think, this really goes to the heart of today's conversation, which is the narrative framing of the crisis as a white problem has changed the rhetoric and has certainly spurred more investment than, the drug crises of the past in the response, but the response hasn't really addressed the underlying issues, and that's why we're seeing it continue to spiral. And the myth is really a twofold, which is, since it's a white problem, we've taken on a public health response, and I think both of those elements are myths that need to be debunked.
But even further, if I can, Leo, real quick, to that law enforcement response, it is also how we have alienated folk who would be willing to respond to overdose when it's seen, but because of law enforcement also putting that narrative out there that you can die from touching it or being around people who have it, and yet we've not had enough of a response from the federal government, from DEA, law enforcement organizations to say this is not true. So it further, here we are saying we want to spend all this money to saturate the United States with naloxone, but we're still not changing the narrative. And even now, how the market has changed as a result of xylazine and other, adulterants entering, that supply, we again are doing some of the same things and expecting different results. And what we see is those numbers continue to climb.
That's it. And
Yeah.
the overdose phenomena is unique to North America. So, we always talk about anti-Blackness that's baked in, right? Black, Indigenous, people of color is a nice catch-all phrase, but really what's baked into these inequities is the anti-Blackness that is not just unique to the country. We've operationalized it really well, but it's all over the world. So we talk about Portugal and how Portugal is doing it. Portugal doesn't have the anti-Blackness built in. So they had a public health response right from jump, and they don't have overdoses. I've been to meetings where people have come in from, West Africa and from, the Philippines, they're just shooting people who use drugs. But in Brazil, they have no fentanyl. And they've always built in a harm reduction approach, although who's delivering the harm reduction is problematic. But the despair is here in North America, where we are so duplicitous in what we say and what we do. And so we won't be able to teach anybody anything if fentanyl makes its way into other countries' drug supplies, because we're screwing it up here. We have politics driving, and again, the flashback to HIV, because we had the same discussions about syringe exchange, right? Same discussions about SSPs. And the fact that they have, the science is solid about lives it saves, about connecting people to other kinds of care. And mind you, I didn't say treatment. Syringe programs have connected people to other kinds of care that people are able and given the dignity to articulate that they need. This focus on treatment, which is part of the reason that our experiment in decriminalization in Oregon, which of course has landed really foully on the Black people in Oregon, they are there, is because there was this very cynical belief that you just needed to decriminalize and then give people cards to connect them to treatment. Treatment is carceral light, the way we've set it up in this country. Treatment is not about people getting better. Treatment is about fixing you up just so you can keep coming back, because treatment's business model is based on the fact that you will fail. And if you don't die, you will come back. And then, of course, we have it hand in hand with our criminal legal system that ensures that you will be coming back or you will be in a jail. The fact that we are looking at making agonist treatment more available in the correctional environment would not be happening if there weren't so many white kids who were sent to jail as a way to get treatment, because the parents were being told that's where treatment could be paid for when a judge mandates you to go. The fact that these parents were sending their children to Florida to these rip-off treatment programs in Florida and didn't know anything about agonist treatment, didn't know about methadone, didn't know about Suboxone, and it's just so much impacted by the racist anti-Black propaganda and systems that are still in place. So when we talk about opioid settlement dollars getting to where they need to get to, we really need to keep in mind the disaster of tobacco settlement. That money is already being supplanted, being used by states and localities to fit their own needs and not having it go to where it needs to go. And our folks don't know about this money. I could say that with confidence.
Oh, you just put it out there so powerfully, Tracy. And, for those of us who've been thinking, well, okay, what is the solution? If the solution is not locking people up more, if the solution is not quote unquote treatment, the way you describe it, if the solution is not putting more money into public-private partnerships with pharma, then what is it? And I do think that Black harm reductionists are leading the way. It really is political organizing and political activism, because the root cause is the racial oppression and the class oppression that we've just described. And how do you push back on that? It's a political solution that must be driven by the people who are most oppressed. Otherwise, the agenda goes haywire. And I just wanted to also shout out to harm reduction organizations that really take on racial oppressions as political agents. These are places where people do learn about the context for what they're experiencing, the history, the economics, the politics of drug policies, and what they can do to push back. And Tracy, you're quite right about the history of HIV activism. I do see some very hopeful moments in the history of HIV activism, in that no, the gay white men did not in the end drive the whole agenda. And the reason why there was attention to pediatric HIV, to women with HIV, to people who injected drugs in HIV, was the brave and powerful activism of people who fit into those categories and who were often based in harm reduction organizations. And so and the things that came out of that are very inspiring. The fact that Ryan White CARE Act had this clause that community councils had to decide where the money went, and that those community councils had to have HIV positive people, directly affected people. And what did those councils do? They decided to use healthcare dollars for housing. That was a big innovation. They decided to use healthcare dollars to pay people with lived experience of HIV to be part of the care team and do the peer navigation. So a lot of innovations came out of that. And so that's the stuff that keeps me inspired. How can we push back politically? Because this is a political problem. It even goes beyond public health problem. This is a public health problem that's deep. It's actually a politically caused public health problem. So the solution has to be a political one. And who should drive that? I nominate Black harm reductionists. And I will include Black and brown. I'm thinking about our brothers and sisters that are Native American, that are losing people right and left. And the overdose rate is going up among Latinx people. And we just talked about immigration policy, and that is weighing very heavily on our Latinx brothers and sisters. So I just want to say, I think this is a political problem, and we, especially in Black and brown communities, have to recognize it and as a political problem and grab it by the collar, because we will die off from this and we are dying off from this, but we will continue if we don't.
Can we get your book in some curriculums, please?
Thank you for mentioning my book. So a lot of what I just described in the beginning of the history of the whiteness, the perceived whiteness of the opioid quote unquote crisis, I wrote up my decade-long research with my co-authors, Jules Netherland of the Drug Policy Alliance and David Hertzberg of University of Buffalo, in a book that we call Whiteout: How Racial Capitalism Changed the Color of Heroin and of Opioids in America. So thank you for that shout out, Tracy.
Absolutely.
And Mark.
And we'll post a link to the book when we post the podcast, so that will be here for folks to access.
I'll have some information about the link for Black Harm Reduction Network, which is, as Mark said, it's been percolating at Legal Action Center, where I am until May of later this year, because Black Harm Reduction Network is going to be launching as an independent organization. And there is so much excitement about it. We have a board of directors already. Mark is on the board. That should be no surprise. But we're going to be providing technical assistance and also working in our communities, by us, for us. And one of the first issues we're going to be addressing is despite the fact that it's the thing, naloxone is not getting into Black communities as much as we are depending on it to be the thing. And so we are going to be working with Vital Strategies and the Elton John Foundation to identify places in this country where Black overdose is especially high, and try to discern what is going on in terms of naloxone not being more readily available. What are some of the issues about people not wanting to use it? That notion of enabling people is very much baked in and distasteful to a lot of folks, but our folks in particular, because of the propaganda of shame and stigma, I think make it even more challenging. So you'll be seeing lots from the Black Harm Reduction Network, and we're probably going to be passing out copies of Dr. Hansen's book as we go around the country.
Wow, thank you.
Mark, you want to end? You're I call him the elder statesman, because he's seen so much, done so much.
And continue to really try and stand up syringe service programs as still one of the lifebloods of harm reduction. And being forever grateful for, I'll give a shout out, yes. And while we're building the BHRN, I'm grateful for Dave Purchase, for Dan Bigg, Mark Kinsley, very close friend of mine, and even Shiloh Jammer, folk who made sure that syringes were available to other, people. And that's what, when you hear me talk about RHI, my other organization is to make sure that we can get syringes into those communities that don't have access, because I understand more than anybody else who worked for other programs and have now built mine from a backpack to serving over half of the state of Connecticut, what it takes to really just get on the ground and get that work, and how that work can better be done by people from those communities. But you have to get there, and you have to be able to equip them, to educate them, and to make sure that they have the resources. So that's really my movement moving forward, is to make sure, and not just, it's just really that we stay true to those basic and core principles, and make sure that we have those tools available for a full and robust harm reduction model.
Yeah, absolutely. I mean, I think that even, you know, even the sort of technical program-based solutions that are much more mainstream, we've failed to reach a lot of Black and Brown communities with syringe services and naloxone and buprenorphine and methadone and all of the, even in the absence of the structural solutions that we've talked about, true public health solutions, those communities to continue to be much more burdened with carceral approaches and incredibly resource poor in terms of responding, even just with the technocratic elements that are available elsewhere. So thank you.
I think,
yeah, go ahead.
We developed a turnkey model when we identify those stakeholders who would like to go down this road, where we can go in and provide those services and drop those resources in place, and then help them to build from there.
Absolutely. So thank you so much for your time and all that you do. We're going to wrap up our first inaugural episode of the Changing the Narrative podcast, where we talked about the myth that the opioid crisis, quote unquote, or opioid epidemic is a white problem, and that it has sparked public health solutions. And stay tuned for our additional episodes on the themes of race and the overdose crisis response, that will be hosted by our leader, Tracy Gardner. Tracy, do you have any closing thoughts?
A reminder to plug in my laptop. Leo, thank you for this opportunity to, number one, talk to two people I admire so deeply. I'm probably embarrassing in my slobbering over them, but I think this conversation is one that needs to be had over and over again. We really were able to get into some critical issues, and so I'm going to be looking to get this podcast out as widely as possible. This was a bunch of gold, platinum.
Amen. Thank you all so much, and we'll see you next time.
Thank you.